Here at ONS 2010 in San Diego, California, with us from Philadelphia, PA, my hometown, is Barbara Rogers, a hematology-oncology practitioner at the Fox Chase Cancer Center. Thanks for coming all the way across the country to talk with us.
Thank you very much. It's good to be here.
Barbara, what are the major areas of concern in treating elderly patients with lymphoma?
So some of the big concerns is related to the fact that patients who are older may have more difficulty in being able to tolerate the treatment. So they may have more toxicities associated with the treatment. But because of that, and because of our concerns regarding their ability to tolerate treatment, sometimes we may modify their treatment in preparation for the fact they may be less tolerant. So we may modify the doses of their treatment, may give them perhaps different drugs that could potentially impact their overall response to treatment. We know that patients who are older have more problems with their blood counts when they receive their chemotherapy. And that's a big concern of nurses also. And when we ask them before about their concerns, myelosuppression comes up frequently as an issue in the elderly and being able to treat them. In patients with lymphoma, we know a lot more perhaps than in other types of diseases because there have been many studies looking at the elderly in lymphoma. But we still know, though, that patients who have modified their treatments may not do as well. And so we still have to look further to figure out better ways that we can treat patients who are elderly to make sure that the changes and the assumptions we make are correct. There also are issues related to the various treatments, and not all of them have been tested fully in the elderly. While many of the studies include elderly patients, they don't always focus specifically on the elderly to know that their responses may be the same as what we anticipate in the full group that was treated. And not always is it reported the differences in response rates between the older population and the younger patients.
Are there any particular studies that look at treating the elderly with lymphoma?
The best one is the study that was done looking at the combination of rituximab with CHOP chemotherapy in diffuse large cell lymphoma. And that study, which is known as the GILA trial, was actually done specifically in the elderly and now has been used to change the way we practice in treating patients with diffuse large cell lymphoma, and now the standard of care is R-CHOP. We actually have more information in the elderly in that setting than we do in the younger population because of those studies that were done initially and got the combination approved for the treatment of diffuse large cell lymphoma.
Are there comorbid conditions that affect the way elderly are treated?
Well, the main one I would think of would be cardiovascular disease. And when we think about combinations that include anthracyclines, cardiac disease is a significant concern in that we may make it worse based on using anthracyclines. At times, practitioners may make the decision to not provide patients with the anthracycline in their treatment combination because of those concerns. We don't yet have good data to show what's the best way to treat patients who have cardiovascular issues and whether we should make those modifications and how we should make those modifications to make it safe for them but still get an optimum response to treatment. Another one I can think of would be pulmonary toxicity, specifically related to patients who are being treated with bleomycin in Hodgkin's disease. There is an older population who gets Hodgkin's disease. While we think of Hodgkin's disease primarily in the young population, it does occur in the older patients also. But we do know that patients who are over the age of 70 are more likely to develop lung toxicity from bleomycin than the younger population. And so frequently we may opt to not give bleomycin in that population because of the increased risk of the pulmonary toxicity. Those are really the main ones, although we do have other concerns as patients get older. If they have diabetes, they may have peripheral neuropathy, so it may impact other drugs that we give that can also cause peripheral neuropathy. And if they have renal toxicity or renal issues already as they get older, that may also impact some of the drugs that we can give them.
Barbara Rogers from the Fox Chase Cancer Center in Philadelphia. Thanks for showing us a little brother or sisterly love.
Thank you.
Barbara Rogers here on Oncology.TV.